right. Welcome everyone to the 2023 PI conference. My name is Julie Magnuson and I will be your moderator for today's session, the autoimmune polyglandular syndrome type 1. I'm excited to welcome Dr. Leonakis, who will be presenting this topic. There will be time for questions at the end of the presentation, so please submit any questions you have to the presenter in the Q&A section of the platform. Dr. Leonakis is a physician scientist and head of the fungal pathogenesis section in NIAID's Laboratory of Clinical Immunology and Microbiology, where he is deputy chief. He obtained his MD and SCD from the University of Crete, Greece. He did postdoctoral research training at MD Anderson Cancer Center, followed by internal medicine residency at Baylor College of Medicine, an infectious disease fellowship at NIAID NIH. He established his own laboratory in 2012 at NIAID and received early tenure in 2017. Dr. Leonakis' integrated bench-to-bedside research program is based on clinically relevant mouse models of fungal disease and large cohorts of patients with inherited or acquired susceptibility to fungal infections, and focuses on understanding the genetic and immune defects that underlie susceptibility to fungal infections in humans and on cellular and molecular factors that regulate the immune response against fungi. His work has defined precise genetic, biochemical, immunologic, and cellular disease mechanisms that have led to targeted immunotherapies. He has identified interferonopathy as a critical driver of mucosal candidiasis in patients with APS and has identified local neutropenia due to impaired microglial neutrophil crosstalk as a critical driver of central nervous system targeted candidiasis in patients with CARD9 deficiency. He has delineated novel inherited and acquired immunodeficiency states that increase invasive mold infection susceptibility. Dr. Leonakis has published over 220 peer-reviewed papers in journals such as Cell, Science, Science Translational Medicine, Science Immunology, Nature Immunology, JCI, Journal of Experimental Medicine, Cell Host Microbe, Cancer Cell, and others. He is a member of the Association of American Physicians, a fellow of the AAAS, a member of the American Society for Clinical Investigation, a fellow of the American Academy of Microbiology, and a fellow of the Infectious Diseases Society of America. He has received several awards, including the NIH Directors Award, the NIAID Outstanding Mentor Award, the NIAID Merit Award, and the I. Oswald for Early Achievement, the Junior Investigator Award from the Immunocompromised Host Society, and the American College of Physicians Walter J. McDonald Award for Early Career Physicians. Thank you for joining us, Dr. Leonakis. The floor is all yours.
Thank you so much for this very, very kind introduction. Let me share my screen. I hope that you can see it and you can hear me well. So I think on the basis of that introduction, it might make sense how I got interested in APS type 1 or APS from the fungal infection susceptibility angle of it. That was about a dozen years ago. What I'll try to do over the next 25, 30 minutes is provide an overview of these life-threatening autoimmune syndrome through the lens of now 10 years of experience following at the National Institute of Health, the largest cohort of this disease in the world of about 180 patients, where we've taken an approach to not only focus on one or two or three particular problems that these patients have, but rather look at this disease as a whole and try in the process to understand it, learn about it, and hopefully help patients. So what I'll start with is a representative patient that I think highlights some of the challenges that we face with diagnosis and treatment, and how taking an approach that I outlined earlier can actually enlighten us about things that many of which were not actually in the literature. So this is a girl who at 3 months of age developed this urticarial eruption. It would last for a week, would go away, and then would come and go up until the age of 3, after which she never had that again. At about 6 months of life, she had oral candidiasis. And then starting at about a year, she started developing multiple pulmonary infections, as they were called. About a year later, she developed gastritis, hepatitis, enamel hypoplasia, nail dystrophy. These pulmonary infections did not stop. At the age of 6, she was diagnosed with bronchiectasis. Now, at the age of 4, she developed hypocalcemic seizures, which led to the diagnosis of hypoparathyroidism. And at that time, at the point when she already had hypoparathyroidism and candida, APS was suspected by her physicians. Now, at the age of 8, her pulmonary problems worsened. She would have cough and fevers. She would grow staphylococcus and pseudomonas from her lungs. And she came to us actually now 8 years ago in order to see what might be happening from her pulmonary standpoint. Now, summarizing her clinical history, I've highlighted here in red the 2 of the 3 classic triad manifestations of chronic mucocutaneous candidiasis, hypoparathyroidism, Addison's disease, the 3rd, that are quite characteristic for this syndrome and well known for these features. However, as you'll appreciate, through the course of time, for several years, actually, the patient would go to physician after physician with other disease manifestations that did not trigger an alert that this might actually be APS1 or APS. We'll come back to that in just a moment. When we saw her at NIH, she didn't have a fever, but she would not maintain a normal oxygenation after doing a 6-minute walk. She had abnormal pulmonary function tests with an obstructive pattern and decreased diffusion lung capacity. And her CT scan was not normal. She had these ground glass opacities, bronchiectasis, and if we look at this view, you can see also mucus plugging, which was the sequela of what turned out to be uncontrolled autoimmune pneumonitis for quite some time. So what is APS1 or APS? It's a recessive syndrome caused by mutations in the autoimmune regulator gene, or AIR. It causes a very characteristic signature infection, chronic mucocutaneous candidiasis, or CMC, like this patient, and then multi-organ autoimmunity that was initially reported by our Scandinavian colleagues as it's prevalent in Finland to be primarily an endocrinopathy. You can see here highlighted in blue endocrine disorders. Candida, if you take these 3 disorders, they make the classic triad. If you have 2 out of these 3, that's sufficient actually to make a clinical diagnosis, followed by genetic testing or autoantibody testing for type 1 interferons that are quite prevalent. Now, what is wrong in the absence of air? So all of us express air in our thymus in specialized epithelial cells that are called medullary thymic epithelial cells. And because of air, we're able to recognize T cells that would otherwise recognize self-antigens. And as a result of that, we eliminate those T cells through a process called negative selection. In patients who have APS or APS1, this process is not functioning. As a result of that, self-reactive T cells escape in the periphery. They go and infiltrate into tissues. They actually cause tissue inflammation, destruction, and organ failure. So as I mentioned earlier, 10 years ago, we actually saw the first patient here at the NIH Clinical Center. The decision back then was to actually focus not only in one aspect of the syndrome, in this particular case, maybe mucosal candidiasis, that was the primary interest of initial engagement with this disease, but rather I assembled a team of physicians across 10 different NIH institutes, all of whom have seen these patients with us at the clinical level, and a lot of them have helped us in our research when it comes to all facets of this syndrome. It's been a very, very gratifying journey to see all of these patients with all of these colleagues. These are members of my group, both clinical and bench scientists and clinicians. And what we do when the patients come here at the NIH is we do a very uniform clinical evaluation, regardless of what the patient is complaining at the time that they will come at the NIH for their visit. Everybody gets a whole genome sequencing, and they undergo a very, very comprehensive clinical research evaluation that goes from studies in the blood, urine, stool, imaging, and then procedures that are clinically indicated, but at the same time, we aim to actually understand pathogenesis through that avenue. As I mentioned, we've seen close to 180 patients now. We recently published on a prevalence study, an estimated prevalence about 1 in 100 to 200,000 patients in the United States. So there are probably a few thousand patients with this disorder here in the United States alone. So much more work to do to identify them. And part of the reason why this has gone unrecognized for a while is related to the first of the 2 things that I want to particularly highlight today. So today we'll briefly talk about how the syndrome presents, what are diagnostic features, and how this could be enriched to maybe lead to earlier diagnosis. And then highlight key elements of what we now appreciate as individualized patient management, depending on what the disease manifestations of the individual are. So starting with this first, what was very evident as we were seeing patients in this very comprehensive clinical evaluation and research evaluation we're doing is that there's a lot of non-endocrine diseases that happen in this disease. There are over 35 different disease manifestations that can manifest, and obviously not every patient has all of them, but there are patients who have over 15 different disease manifestations. Out of these 35, only 5 or 6 are endocrinopathies, the vast majority of them being non-endocrine diseases. And what was very prominent from early on is that 6 particular diseases, enteritis, hepatitis, gastritis, pneumonitis, a very characteristic skin rash that this patient actually that I mentioned earlier had at month 3 of age, third month of age, and Sjogren's are quite prominent and poorly characterized before. Now, what was also very evident is that all of the classic diagnostic criteria that are available, remember, any dyad among candidiasis, Addison's disease, and hypoparathyroidism are actually very good criteria, but they're not very good criteria when a parent takes a kid in the pediatrician early in life when these first manifestations develop. So the mean age of reaching a diagnostic dyad is about 7.5, 8 years. However, 4 out of 5 patients with APS would go on and develop a median of at least 3 non-triad manifestations before developing a classic diagnostic dyad. I think this was highlighted in this particular vignette I shared with you in the beginning, when the patient had Candida, had the rash, then developed 4 or 5 different disease manifestations, and then developed hypoparathyroidism that eventually led to the suspicion for the syndrome. So as we were characterizing what those early other manifestations might be, this APS rash, as we call it now, was very, very prominent. Happens in about 70% of the patients. Together with Candida are the 2 first common manifestations, as in this vignette. It's a very characteristic neutrophilic dermatosis. So these are MPO positive neutrophils in the skin of these patients. It can cause also deep paniculitis. And it's a mixture of T cells and myeloid cells infiltrating in the skin. When we looked at all disease manifestations that can happen early and frequently, we actually came up with what we now call an adjunct triad of this APS rash, intestinal malabsorption, and enamel hyperplasia that, as you can appreciate here, happen as frequently and as early as the classic triad manifestations. And we propose that we should combine those triads into a hexad that can potentially be combined into proposed expanded criteria that could lead to earlier diagnosis. Indeed, when you use any 2 of these 6 manifestations, you can make a diagnosis and accelerate it by about 4 years, so halving the time for diagnosis. And that actually at the practical level would mean that about 50% of patients who would be diagnosed before presenting with adrenal crisis or hypocalcemic seizures, like this individual, the patient that I presented earlier, if they would have been recognized through these expanding criteria. We've went on to validate this criteria now in independent patient data sets, not only from the North America cohort, but also from European patients. And as you can see here, these criteria hold, which has major implications with regards to how we understand the syndrome, in the sense that the clinical spectrum of APS1 is broader than previously appreciated. Affected children in the United States and beyond, I would say, are likely to be seen by many other specialists before they end up seen by endocrinologists. Endocrinology colleagues are very savvy on recognizing this disease. All of the rest of these specialties are not yet. So I think there's a lot of work to be done to raise awareness through expanding criteria I mentioned earlier, but also other means. And this has major implications for management, because you can imagine a situation where you could do screening for Addison's disease or hypoparathyroidism, but also perhaps get to a point where we might get to implement prophylactic immunomodulation, which is something that we want to do as a next step. So this is an example of how recognizing this characteristic urticarial eruption, which we call APS rash. Now, this is a 10-month-old, is a sibling of a known APS patient. This is the first manifestation. This girl was then put into a screening approach. She did not have to develop hypocalcemic seizures because we detected the calcium aberrancies that happened 3-4 years later. That can be modeled for other patients. Now, this raises interesting opportunities for potential early intervention in the future, whether that might be in the form of thymic transplantation that has objective limitations, at least in 2023, or an approach by which we take a prophylactic immunomodulatory approach and try to halt the progression of the disease at this very early stage. This is actually an aspiration of ours to do at NIH through a randomized placebo-controlled trial in the future. Now, the second part of my talk will briefly highlight how we would approach an individual with APS. Again, it's a diverse syndrome, as you've heard from other talks. Monogenic diseases do have one gene that is impaired, but there is dramatic variation in how patients present. So what I'll try to do very briefly is provide some key highlights with regards to how we think of managing a patient who has APS1. Dividing these in endocrine organ failure, non-endocrine organ damage, and candidiasis, the three components of this syndrome. When it comes to endocrine failure, a couple of important highlights to make, again, endocrinologists are savvy with that, is to avoid as much as possible over correcting calcium, because that ends up in the kidneys and causes nephrocalcinosis and renal failure. We've actually successfully implemented, as opposed to IV calcium infusions that can do that, procedural recombinant PTH, very successfully without the need to give intravenous calcium. We published that a couple of years ago. It's very important to manage adrenal insufficiency properly, both from a standpoint of carrying a bracelet, having parenteral hydrocortisone, and then in patients who don't yet have Addison's disease, an ACTH test to screen early on before adrenal crisis happens. A few highlights with regards to non-endocrine organ disease. As I mentioned, in this particular patient who had pulmonary lung disease for several years, it turns out that almost 45% of APS patients develop autoimmune lung disease. It's often mischaracterized as being asthma or bronchitis. These patients get chronic colds. It's very important to do a CT test on everybody. And it's important to treat before the development of bronchiectasis, because that can actually prevent life-threatening complications. So when you take a biopsy of the bronchos of these patients, you see this very thick layer of brown CD3 T cells. Again, these are self-reactive T cells that recognize self-antigens in the bronchial epithelium. And then when we do a deeper biopsy into the bronchioles, you see bronchiolitis, autoimmune bronchiolitis, and again, a lot of T cells around the area of bronchiolar tissue, with also now B cells aggregating into the deeper interstitium. So when we take mice that have also APS or APS1, we find a very similar lymphocytic infiltration in their lungs. And in mice, we can ask the question, how can we treat it? Is it the T cells or the B cells that predominantly cause the disease? You can see here an APS mouse that T cells have been depleted. Their lungs look completely normal. When we remove the B cells, we still get some disease, but less so. So on the basis of this experimental data, we hypothesize that if we target those lymphocytes with immunomodulation, we could potentially halt the progression of the disease, remit the disease, and avoid the complications that we can see in patients such as respiratory failure, home oxygen need requirement. On the basis of now treating about 20 patients with APS with a combination of azathioprine and rituximab, I'm going to show you one example, the patient that I presented in the very beginning. This is collectively the dramatic responses radiographically, where almost all radiographic abnormalities go away. So let's remember this first patient who had these very thick nodular opacities within a month of treatment, and then sustained at 6 months a result. These are coronal views that show exactly the same. Now, again, over the course of years, we've treated over 20 of these patients. They all have favorable responses that are durable, some with requiring redosing with rituximab every 1 to 3 years. When patients develop autoimmune liver disease, which also happens about 40 to 50% of the time, it's important to recognize it. Sometimes actually the liver enzymes don't go very high, like in classic autoimmune hepatitis that happens outside of APS. And many times classical biomarkers that are often tested by astute clinicians are negative. That does not mean that the patient doesn't have APS-associated hepatitis. So a biopsy is critical to avoid a liver fibrosis and eventual cirrhosis. But the good news is that as a thioprim or CellCept that is also effective against the lung disease, as I mentioned earlier, also controls autoimmune liver disease. Now, about 80% of the patients can develop an intestinal malabsorptive syndrome that can have multiple etiologies. Some patients have exocrine pancreatic insufficiency. Most patients have autoimmune enteritis. And many patients also, on top of that, can have small intestinal bacterial overgrowth. It can be severe enough to require total parenteral nutrition in a subset of patients. It involves primarily the small intestine. It causes fat malabsorption in the majority of the cases. And through a very systematic characterization of what I mentioned earlier, we now have an algorithm in place that actually can remit almost all patients, including those that have multiple bowel movements a day and malnutrition. Some patients get autoimmune gastritis, again, about half of them. It can be together with pernicious anemia leading to B12 deficiency. Intestinal metaplasia, as seen in this particular slide, can happen in some of these patients who can be at risk for gastric cancer. So gastric mapping and surveillance is important. And in a minority of the patients, actually, they can present with gastroparesis like diabetic patients do. That can also respond to immunomodulation. Again, about 40 to 50% of the patients develop a Sjogren's-like syndrome that was, again, poorly recognized, particularly probably at large because the classic autoantibodies that we use for classical Sjogren's syndrome are negative in this disease. So there are different autoantigens that the autoimmunity is targeting. And again, this can be responsive to immunomodulatory therapy for liver and lung disease, thereby having patients restore their salivary and tear production, resulting in resolution of dry eyes and dry mouth when this happens. Keratitis is a particularly important entity that, unfortunately, even in 2023, can sometimes be missed or ignored. When patients present with dry eyes or photophobia or pain, it's important that they see an ophthalmologist. It's actually routinely every year that they do so, because keratitis that happens in about 35–40% of the patients, if it's left untreated, it can actually lead to scarring and even blindness. So topical cyclosporine is the mainstay of treatment, and it should not be interrupted when the patient responds. We've seen patients who responded and then they were taken off and then that progressed. Another important entity that is critical to keep in mind is that about 20–25% of the patients develop asplenia. They're not born without a spleen, but through presumably a T-cell autoimmune attack in the spleen in adolescence, they actually lose the spleen. So this is a CT scan where the spleen should be here and it's missing. That raises the risk, as we all know, for asplenic patients of any etiology to encapsulated bacterial infections. So it's important to screen with imaging and a peripheral smear that can show whole jolly bodies, or when suspicion arises and the whole jolly bodies are not there because they're not very sensitive, a liver spleen technician scan to conclusively make a diagnosis, because prophylactic antibiotics and vaccinations are critical to implement in order to avoid fulminant sepsis with pneumococcus or meningococcus, which we have seen in our cohort, sometimes with fatal results, unfortunately. The last item on the non-endocrine manifestations that I wanted to briefly highlight is anemia. There are three major causes: iron deficiency, primarily through malabsorption in enteropathy patients; B12 deficiency associated with gastropathy, as I mentioned; and rarely, but very dramatically, red cell aplasia. This is an example of a patient who had no red cell precursors mapped by CD71 here. All this is negative. That means that they have an autoimmune attack in their bone marrow. They don't make the red cells. The treatments for those would be supplementing iron and B12. But in the case of red cell aplasia, actually intense immunosuppression with T-cell depleting agents is needed, as opposed to azathioprine or CellCept or rituximab wouldn't work in this particular entity. Now, I'm going to end with a few slides about the management of candidiasis. Okay, about 85% of patients do develop recurrent oral thrush or esophageal candidiasis. It's important to treat it because it can be associated with esophageal strictures. It can be associated with oral and esophageal carcinoma. So it's important to treat the candida when it happens. And it needs to be done properly because the resistance can develop despite the use of antifungal therapies, which can make long-term management challenging. So the way we approach this is we always get a culture. We do susceptibilities. We need to know what the candida species is and what it is susceptible to. We treat the patients in the acute episode with a month of treatment, either a nasal if susceptible or an echinocandin if azole resistant. And then the decision of whether we will continue someone on secondary prophylaxis, that is on something that will be antifungal to prevent the candida from coming back, depends on how quickly they relapse after they get this month of therapy. If they relapse once every year, we don't keep them on prophylaxis. If they relapse soon after this first month, what we do is we put them on oral amphotericin B, Swiss, and swallow, as resistance to amphotericin B is not easy to happen. Actually, amphotericin B works much better than nystatin that many times patients are put on, and they don't quite respond well with that, but they do respond to amphotericin. And in only a very small minority of patients do we need to keep them on a chronic fluconazole regimen. So most patients can actually be treated and stay away from having recurrent candidiasis with these basic principles. So to conclude, what APS1 or APS is a multi-system disease that results in specific infection susceptibility to candida and multi-organ autoimmunity that expands way above and beyond the endocrine system. Expanded diagnostic criteria and increased awareness may have important implications in early recognition and improve patient outcomes. I think from early recognition of disorders that might come is the obvious first step. But at the 30,000-foot view, whether we could actually implement a prophylactic immunomodulatory approach so that the 2-year-old who only has had candida and enamel hypoplasia perhaps gets on an anti-inflammatory and immunomodulatory agent and they don't develop any other manifestations. I think this is an aspiration of ours that we want to implement. And on the basis of now knowing how to actually treat established disease, we're confident that this is feasible. I think it's also important to highlight that this is really a multi-organ syndrome that requires a multidisciplinary team of physicians, a proactive targeted screening approach, and defined diagnostic and treatment algorithms in order to reach good outcomes and improve quality of life of the patients. We're more than excited at NIH to evaluate any patient who has APS1 or APZ from the United States or anywhere in the world. The APS1 Foundation is a major partner of ours. Is a wonderful community of parents, patients who support each other. So this is an impressive support group, the way I've seen this develop over the last 10 years. What I'm going to end is a little bit of a teaser. I'm not going to go into this in great detail today, but as it highlights here in the website of the APS1 Foundation, we actually just launched the first ever clinical trial of APZ using ruxolitinib, which is a JAK inhibitor, on the basis of data that I didn't show you today, but do indicate that excess interferon gamma responses actually are the main driver of this syndrome, both for candida, but also for autoimmunity. And on the basis of very promising first early data that ruxolitinib actually can cure mice from this disease and can put patients into impressive multi-organ remissions. We've already started enrolling patients with alopecia being the primary endpoint, but quite frankly, all of the syndrome being very scrutinized and responsive. And with that, I would like to thank you for your attention, and I'll be more than happy to take any questions.
All right, thank you so much, Dr. Leonakis, for that overview. We do have time available for Q&A, but before we begin, please remember that everyone's treatment and condition are unique. The information presented during this session is not medical advice, nor is it intended to be a substitute for medical advice, diagnosis, or treatment. Always seek the advice of your physician or other qualified health provider with questions concerning a medical condition. Now, again, if you have any questions, please go ahead and post it in the Q&A here on the platform. So we do at least already have a few good questions coming in. So first question, do you see a correlation between CVID and APS?
So, CVID is a very, very broad term that encompasses many disorders, some of which more recently, through next generation sequencing, have been given actually a genetic diagnosis. And even within that umbrella term of CVID, there are many, many different diseases, some of which have very different ways by which they can be treated. So APS is not CVID. A small minority of patients with APS can present with an inability to produce antibodies, and they might need IVIG the way that patients with CVID might also need to. There are some commonalities with the autoimmune lung disease that CVID patients develop with the APS-associated autoimmune lung disease. Actually, the regimen of azathioprine with rituximab, before we used it for APS lung disease, as I highlighted earlier, was first developed by Jack Roots and others for CVID-associated pneumonitis. So they're different entities. Some APS patients can develop a CVID-like picture, but they're not really the same entities, if it makes sense.
Great, thank you. All right, our next question. If you live with chronic candidiasis, can the frequency and severity of infections change over time? If so, what can impact these changes?
So, both for APS, but also for many other diseases that can present with chronic mucocutaneous candidiasis, the way by which Candida can recur can be very, very different from patient to patient. We don't quite understand that. Second, even within the same patient, there might be periods of time where they might have more frequent recurrences, and then they go for several months or years without much of that. When it comes to APS, some factors that might actually lead to more frequent recurrences is whether they've been on steroids for autoimmune manifestation treatments. For example, someone had hepatitis and they were placed for 6 months on steroids together with azathioprine. That can make their Candida much more difficult to treat. I would say a common feature that we've witnessed over the last few years, seeing a lot of patients on antibiotics, is a common reason why recurrence happens is because of not treating the acute episode with a full month of antifungal therapy. When we treat patients for a full month, as opposed to historically the same patients being treated for 10 days or 14 days, we see dramatic improvements in how frequent their recurrence is and how far in the future they will be. So I would say that would be one feature for patients to be aware. When they have a genetic cause for having chronic mucocutaneous candidiasis, it's important to treat for a whole month, because less than that results in recurrences. So that's an important feature that can be actionable.
Thank you. All right, our next question here. At what point should I try to convince my PCP to take a closer look at my seemingly common upper respiratory symptoms?
And this is a patient that has APS1? Or
not specified?
Yeah. So I would say, given that we're talking about an overview of APS1, let me start with that. So a patient who has a APS1 or APS that has chronic cough or chronic respiratory symptoms, it's very important to be evaluated for the potential that they might suffer from autoimmune lung disease. As I mentioned earlier, 40 to 45% of patients can develop that, and it is not uncommon that they get labeled as having asthma or they have chronic colds. So a CT of the chest in an APS1 patient who has chronic respiratory symptoms is a very important modality. We do it on every patient because about 10 to 15% of patients actually who have interstitial lung disease do not even have symptoms at the early phases. So if we identify it early with a CT, we actually implement therapy that can alter their outcome. So if someone has chronic symptoms and has APS1, it's very important that they get a chest CT.
All right, thank you. All right, our next question. Is there genetic testing available for APS?
Yes, absolutely. So It's part actually of major panels from GeneDx and other companies that look into primary immunodeficiencies. We test all of our patients, not only specific for AIR, but through a whole genome sequencing. So if patients enroll in our study, we do a whole genome sequencing, and also that covers AIR. But there are multiple panels and multiple companies that can do a CLIA certified genetic testing to establish a diagnosis.
All right, thank you. Now we do have one last question here. So again, if anyone has any questions, feel free to post them because we do have time available. All right, but the next question is, are there certain medications that are safer to use to fight Candida during pregnancy?
Mm-hmm. So that is a great question. And the question is stemming from the fact that the azole antifungals, such as fluconazole and the newer generation azoles, such as posaconazole or voriconazole, are not safe to use during pregnancy. So there are studies actually from the last 3-4 years, particularly, that have clearly shown that even a single dose of fluconazole in a pregnant woman increases the risk of stillbirth and early abortion and miscarriages. So as a result of that, in a patient who has chronic mucocutaneous candidiasis, using fluconazole is not advised. Ideally, at the time when a patient, through planning perhaps and awareness with their physicians, they are planning to get pregnant, their Candida can be well controlled, be on amphotericin already. As I outlined earlier, amphotericin is a very safe drug, and that would be the best case scenario. Now, in someone who might have very severe candidiasis and is already pregnant and didn't know or didn't plan for it, amphotericin, even parenterally for a short period of time, although long-term can be toxic, can be used. It's again safe. So there are ways to go around it, but it is true that the choices for treatment are limited. So I think the best way to approach this is to work with your physicians, control it with azoles prior, get on amphotericin for secondary prophylaxis that is safe and can be used throughout pregnancy. And of course, there are options, again, as I mentioned, with amphotericin parenterally or other drugs in the event that a systemic antifungal might be needed as well.
Thank you for answering that. Now, again, we do at least have a few minutes, so give everyone just another minute to submit any questions. Also, as a reminder for anyone who may have questions that we are unable to address throughout these sessions, you can go to the IDF website and click on Ask IDF to submit your questions. But I think at least for tonight, we might be ending a little bit earlier. So if there are no other questions, then it looks like our time together is coming to an end. So thank you so much, Dr. Leonakis. It really has been an honor to have you join us today. And everyone, this session is one of 39 unique learning opportunities provided through this conference. So we hope you continue tuning in today as we explore other critical topics for the PI community. Have a great evening, everyone.
Thank you for having me.